Hello, I think we'll get started as more people continue to log in here. So I'm Katie Denham. I'm a nurse practitioner and nurse educator for Medify. Thank you for joining us tonight for our webinar, which I think I saw was like the 12th or 13th in our series, which is amazing. As always, these sessions are recorded and you can access them afterwards for rewatch if you want to. Just to clear it up front, we're going to do a presentation tonight and we'll save questions for after the presentation. So you do have a chat box on your screen, and feel free to throw comments or questions into the chat box at any point throughout the presentation, and we will address them at the end of the presentation. So we won't forget about you there. Other than that, I want to say happy Pride Month to everyone. Hopefully you find some way to celebrate this month, and National Indigenous History Month as well. So it is a big month, June. And being June, I'm glad to see so many people here with us just because of summer vacations as well. So why don't we dive right in, and we'll start with our land acknowledgement, if that's okay. Perfect, thank you. So we acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. These are the ancestral homelands of the Huron-Wendat, the Anishinaabeg, the Mississaugas of the Credit, the Haudenosaunee, and the Attawandarons Neutrals, and is home to the Dish with One Spoon Treaty. Medify recognizes that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. Medify respects that Indigenous people have rich cultural traditional practices that have been known to improve health outcomes. I invite all of us to reflect on the territories you are calling in from as we commit ourselves to gaining knowledge, forging a new, culturally safe relationship, and contributing to reconciliation. And I'm very happy to introduce our speaker tonight. Tali Cahill is here. She is a nurse and she's very graciously offered to introduce herself. But I have to say, I'm always very excited when we have, obviously being a nurse myself, nurse practitioner, I'm always very happy when we have nurse presenters. So extra grateful to be able to be here with you, Tali, and I will let you take over, and we'll see you at the end. Thank you.
Thanks, Katie. So thanks everyone for coming tonight. At least in Ottawa here where I am, it is a beautiful night. So the fact that you're spending any time with me talking about opioid overdose I'm really grateful for that. So today I'm going to talk about opioid overdose protocols in supervised consumption sites and comparing them to bystander response. I'm going to be talking about a little bit more than that, a little bit about how supervised consumption sites in Canada work, a little bit about the supervised consumption site that I've worked most in and where I developed some versions of their opioid overdose protocol. And I'm going to also kind of end with some recommendations about opioid overdose protocols and how to develop them. So who am I? I am a nursing professional practice consultant at the Royal Ottawa Mental Health Care Group, a hospital here in Ottawa. I'm also a community health nurse at the Sandy Hill Community Health Center, and right now I'm just a casual nurse there, but for a few years I was the nursing team lead and developed some of the opioid overdose protocols that you will see here. I'm also the Eastern Canada Board representative of the Harm Reduction Nurse Association, and if you are a nurse and you are not a member, I highly recommend that you check us out. And I don't have any other conflict of interest other than my employers and my board membership. So why am I doing this presentation about opioid overdose protocols and supervised consumption sites? So there is really a lack of published or gray literature on how supervised consumption sites treat opioid overdose, whether it's changed, really not much research about it at all, even if you're in the field. And there's a real difference between that bystander response that you guys will be familiar with when you get a naloxone kit and the response in a supervised space. But that isn't really spoken of. Like, we don't really have written anything about how the response is different. And so that's why, we've talked about it a little bit on the Medify listserv, and why Dr. Wyman asked me to kind of present a little bit more about it. The other thing is, I realize in a group that may or may not include addiction medicine physicians and NPs, I've seen that you all are the ones who are called to write protocols and medical directives for supervised consumption sites. And at the same time, you may never have worked in one, and you may have responded to an opioid overdose as a bystander or in an exam room, and that's really different from a supervised consumption site. The other reason why I want to present is just for the purposes of knowledge translation, because supervised consumption sites are generally not particularly well funded, and they're usually in community settings where they don't have a ton of money for research or knowledge translation or ability for the people who work or even use the sites to present what their experience is. And so I try to take every opportunity to teach people about how the sites work. Often a lot of the research that has been done is not from a clinical perspective, and I'll go into that a little bit more. So just the first thing I just want to clear up, there's so many acronyms in harm reduction and in substance use, and supervised consumption sites, which is my preferred name for them, are called so many different things in the literature, and we keep on making up new terms all the time. So when I'm speaking about supervised consumption sites, I'm kind of speaking in general about places where people use drugs in front of trained responders who are experiencing opioid overdose response. And generally, I'm speaking about the sites in Canada that have been sanctioned for these purposes. So this presentation isn't really about how people who use drugs, who actually respond to the majority of opioid overdoses that happen in Canada and around the world, I'm sure. It's not really about that response, and they're the ones who kind of, really made the call for naloxone to be available publicly. I can't really speak to that as much as I can speak to formal kind of protocolized responses that are written out and algorithms that people follow. So in Canada, we have supervised consumption sites. We also have overdose prevention sites. They're also now kind of called urgent public health needs sites. And really, they might have very similar opioid overdose protocols. The difference is really in the amount of time it takes to get a sanctioned supervised consumption site approved versus an overdose prevention site, and the wraparound services that are provided. So for the purposes of this presentation, I think they're kind of a little bit interchangeable, although if people have, I've had some experience working in an unsanctioned OPS. If people work in a sanctioned one or an urgent public health needs site and want to call me out on everything I said, feel free. If you do a literature search on supervised consumption, there are so many, it's really hard. There are so many different names. They can be called overdose prevention centers, safe injection site, safe injection facility, drug consumption room. In Ontario, where I am, the government made a new name, consumption and treatment site, to kind of reduce the appearance that it's just a place where people use drugs. So that's, I'm sure there'll be another acronym coming out in 6 months from now. So if you're searching for literature about SCSs, that you have to search a ton of different stuff, and to just be aware that they're all kind of the same thing, but a little bit different. So supervised consumption in Canada is regulated by the government, but funded generally provincially. So the government gives exemptions from the Controlled Drugs and Substances Act to allow supervised consumption spaces to open. So they're just rooms where drugs have basically been entirely decriminalized. So it's like a common sense room is sometimes how I like to think of it. They're funded provincially or sometimes by cities, and there are actually a few sites in Canada that are funded completely through fundraising, like through corporate partnerships or individual, which is kind of wild if you think about that for a medical setting. They are somewhat heavily regulated by the government of Canada, but those regulations really speak to they're mostly about drug trafficking and the fact that these sites need to have wraparound services generally, especially for the supervised consumption site versus the OPS. So there are very specific regulations about what happens when we find drugs, what happens when someone has an overdose and there's drugs left behind, what happens if someone takes the drugs that may be left behind, and lots of logbooks and lots of talking about that. And that's the focus of most of the regulations when you apply for an exemption or receive an exemption from the government of Canada to operate a supervised consumption site. There are very few rules about staffing and medical protocols. So the exemption process has changed since the last time I looked at an exemption, but I think it sometimes specifies that it has to be a health professional on site. It doesn't necessarily specify that they need to be in the room. the nature of any overdose response. There has to be one. It doesn't really speak to how that response has to be. So that is really not very regulated, and there's not a lot of stipulations around the medical response part of supervised consumption when you're talking about what the government of Canada cares about. In Canada, most supervised consumption sites are run by public health units, community health centers, some existing HIV clinics. Sorry, there's a helicopter above me, or also local health authorities. And there are a couple in hospitals, but that's not very common. So most of them are operated by smaller settings, or larger public health units. So just keep that in mind when you're thinking about the protocols that we have. You may or may not know, but Insight was the first medical model of sanctioned supervised consumption in Canada in 2003. Obviously, there were sites run, especially in Vancouver, by drug user activist groups before then, but this is the first sanctioned site that the government allowed to stay open. And when you're looking at research or literature about anything about supervised consumption, it's important to know that almost all of it is from Vancouver and from Insight. And there's a very good reason for that. And it's because at the beginning years of Insight, they had to prove that it wasn't, detrimental to the community. They had to prove that it didn't, that it people actually reversed overdoses, that it didn't draw people use drugs to the community, all of these things, mostly from a sociological lens or a law and order lens. And they had to do all of that research and kind of just to prove that they should be allowed to continue to exist. And that research was not done by clinical researcher. I mean, it was done by people mainly researching those kind of sociological things, not really from a medical perspective. So there's very little research or published stuff about Insight until much later about how the overdoses were reversed or anything like that, because it's just not the way they were looking at supervised consumption at that point. They weren't really worried, to be honest, about the quality of care of the people in the site as much as they were worried about what was happening kind of in the neighborhood around and whether or not people were selling or dealing drugs in the site. So before Insight, there were supervised consumption sites in Europe for many years, and there still are, but they haven't been very heavily researched or protocolized, and there's not that much. There's a little bit about their connection to the community. Again, not that much about the protocols that they use to respond to overdoses. And even beyond that, opioid overdose is not as an event is not super well defined in the literature. Like I have wrote my thesis on opioid overdoses, and it was interesting because there's no, what is an opioid overdose? And I'll speak a little bit about what it is and isn't later on in this presentation, but it's not just one thing that we can all agree on. So supervised consumption sites are weird. I didn't really fill in this slide because I'm sure, because it sounds bad, right? They are, but when I'm saying that they're weird from a medical perspective. So you're thinking about a room where drugs have been decriminalized. It's really different from when you're using drugs in your home, and if you had an overdose, the response is really different. At the same time, it's a medical setting where people come to use drugs much as they would everywhere else, but it's often staffed by medical people who have a few more resources than you would have in your home. But it's not a hospital, and people don't have to go there. So it's up to them if they want to go. So there's a certain amount of a customer service element. And all of that mixed together makes our overdose response really different from any other setting. And as a nurse, as a kind of a medical person, that didn't bother me too much until COVID happened. And there were all of these questions about what you could do, what was an aerosol generating medical procedure, what we were going to do CPR, all of that stuff. So everything, there was really no help for people running supervised consumption sites in terms of medical advice and IPAC advice in terms of how to actually serve the people who run the site. And an interesting example of that is that there was a lot of discussion at the beginning of COVID about whether or not we should be doing CPR, because using a bag valve mask is an aerosol generating medical procedure that could transmit COVID. And, there's a lot of discussion on medical, and I think even on the Medify listserv about, well, we shouldn't be doing CPR. The hospital's not doing CPR because people don't often survive CPR, especially a lot of people with medical comorbidities admitted to a hospital. Okay, that's great. But I'm sitting in a supervised consumption site where people are generally fairly healthy, where they absolutely will survive the opioid overdose, like 99 times out of 100 or even more. So I can't just say we're not going to do CPR because it might just spread COVID, because that would be watching people die. If not, we don't usually get to the point where we need to do compressions, but having to breathe for people is quite common. And so this advice that we were originally given, like, oh, just don't assist people with breathing, was not going to work. But it really showed me that there's a lack of understanding in the medical community about what happens in supervised consumption sites. And I had to go back and forth many times with the Office of Emergency Management Ontario for specific advice specific to our site, because there wasn't really an understanding of the kind of people who use our site, who may be homeless or living in shelters. The fact that we couldn't make people really wear a mask very well, although actually the clients are really great about that after a while. But it was a really different setting that people just didn't understand. So that's why I'm just saying that they're weird. The concept of them is not weird, but from a medical point of view, it is a little odd. So let's look at your standard bystander opioid overdose response. This is from Toward the Heart, which is a site operated by the BC CDC. And this is pretty standard for what you get in your naloxone kit. It's basically, recognizing opioid overdose. And they have a few examples on the side. It's pretty small, but small pupils, the non-responsive, blue fingernails, not breathing or gurgling. And then, so you try to wake people up, you check their airway, breathe for them, give naloxone. It's pretty standard. And I've seen some variations of this where you breathe or don't breathe for people, or whether you wait 3 minutes or 5 minutes for naloxone, but this is pretty much what people get in any naloxone kit. This is what's happening in a bystander response. The person may already be down. Now, sometimes people watch people use drugs and can respond right away, and that's great. You might be finding someone down on the ground, so you're not sure, is it an overdose? Is it opioids that they're on? The person who's responding may have a lot of experience, especially people who use drugs who respond to overdoses on a daily basis of with their friends and people around them, or they may have no experience at all, like a family member of someone who's using drugs who just happened to have an naloxone kit, or if you're walking down the street and you have one and you've never used it before and you're responding to an overdose on someone on the street. Location, like you could be rural, you could be downtown, you're not sure, you could be in a bathroom where you're stuck and you can't get someone out. It's not a great space for responding to an opiate overdose. You're often given in naloxone kits a CPR mask. It is hard to breathe for someone with one of those masks. People always worry about vomiting or about infection control. If you've taken CPR, oftentimes they will do compression only CPR and not breathe through people just because of the risk of an infection. So there's a lot of discomfort around that. And it, again, as someone who's done it, it is quite difficult to do compared to using a bag valve mask that you might be familiar with in the hospital. And obviously we don't have oxygen, most of us, sitting around when we're responding to overdoses. So that's bystander response. Pre-hospital response is a little bit different when you're talking about paramedics, because again, the person might be down, but you do have a few more resources. In the emergency department, usually most opioid overdoses resolve well before people get to the emergency department. So what they're seeing is like a later stage overdose where someone may have been given naloxone too late, or some kind of a polysubstance overdose, or an overdose on something like methadone that's long acting where you have to respond for a long time. So these are all different, and they're all very different from what we do in supervised consumption sites. So this is a picture of the main supervised consumption site that I have worked at and continue to work at. And it's very small. So it is 10 feet by 20 feet, kind of the size of my living room as I'm looking around me. It has 5 booths. You're seeing 3.5 of the booths right there. And then there's another booth in the corner. And there's one desk for where the nurse and harm reduction worker work. And this is just an enclosed space. We have a separate very small chill room for people to like post overdose, but this is really where all the action happens. Sandy Hill is downtown Ottawa, and it's near several homeless shelters. We have always, so this supervised consumption site is part of a program for people who use drugs that's existed in Ottawa for about 20 something years. It started out as an HIV clinic and is still an HIV clinic, but also a primary care clinic and addiction medicine clinic. And it's one of 4 supervised consumption sites in Ottawa, all with different opioid overdose protocols. So that's because they're not regulated medically by the government of Canada, people have different protocols everywhere. And so I know that because every site in Ottawa is different. And I've been to sites all around Canada, and it could be that everyone in BC has the same, but something in Alberta is really different. So the protocols are really different. And that's a little bit of why I'm doing this presentation today, to talk about this protocol. So the guiding principles when we originally came up with the opioid overdose protocol, and I can't take all the credit. My colleague Luc Cormier wrote the first protocol, and I helped with some of the oxygen stuff. But basically, 2 guiding principles is that we wanted a protocol that allowed for some clinical judgment. That wasn't like you had to do this then. And we wanted a protocol that did not use a lot of naloxone, because we knew from speaking to our clients that they, found they didn't want to be in withdrawal. And so they were maybe at the beginning not so sure what was happening at a supervised consumption site. When we opened, it was April or May of 2018. There had been an unsanctioned site in Ottawa and another site at the homeless shelter, but a lot of our clients didn't have a lot of experience, and they weren't necessarily sure that we would respond in the right way. So the initial version of our protocol, I'm actually not even sure the origin of the drowsy nodding overdose. I think it's probably from Insight in Vancouver, but we basically had to think of opioid overdose. It's not a binary event. And I think everyone who's seen one knows that. So it's not just that someone is overdosing or not, especially if they're intentionally taking opioids, because there's a certain amount of sedation and intoxication that is the desirable effect, and that's why people might use them. And then there's opioid overdose, where people are unconscious or it's fatal, and obviously people do not want that. So we had to split them up, and this was probably done years ago in Vancouver, and everyone's kind of taken these same words and maybe changed the definitions and changed the protocol since then. So we have drowsy, which is basically someone who is sedated, maybe high, normal vital signs. Nodding, someone whose O2 sat is above 80 but less than 90, or a respiratory rate of under 10. And overdose, which is an SpO2 here of under 80 or a respiratory rate of under 10. If you are familiar with the vital signs of anyone who's in the hospital, you'll see that this is a very conservative. These are very conservative definitions that are also quite broad at the same time. So someone who has an O2 sat of 80 might be perfectly fine, and they might walk around mostly a little bit like that all day long. An O2 sat of 30 is like incompatible, lower and all that is incompatible with life. It's the same thing with a respiratory rate. We normally walk around with a respiratory rate of 12 to 20. We kind of gave it a little fudge room with 10. Obviously, not breathing is not compatible with life, but there are many people, and you'll see in my presentation, who do use drugs who end up breathing at a rate of 7 or 8 times a minute often. So these are just our kind of overarching definitions that are not particularly scientific. I'm not sure what the evidence base is behind these, to be honest with you. So our initial protocol called for, if someone was drowsy, that we would monitor them for 1 hour. If they were nodding, then we would apply oxygen to make sure that their O2 sat was above 92%. We didn't really address the respiratory rate in this for some reason, for many reasons, and I'll get into that later as well. For an actual overdose, SpO2 under 80 or respiratory rate under 10, we would give naloxone. So in this original protocol, we gave intramuscular naloxone or intranasal naloxone repeated every 3 minutes. If someone was breathing, we would put oxygen on with a non-rebreather at high rate, 10 to 15 liters per minute. Or if they weren't breathing, we would breathe for them. And for an overdose where there's no pulse, we kind of do the same breathing thing. Obviously, we were breathing for them with an initial dose of 2 milligrams of naloxone IM. So this is our starting protocol when we opened up our supervised consumption site at Sandy Hill. After a while, we made some observations about how things were going. So at the beginning, there wasn't a lot of experience with supervised consumption in Ottawa, and the experience was very much from a bystander perspective. And also at the beginning of our site, we had a lot of people who were injecting prescription stimulants. We didn't have a ton of opioid overdoses. So it took us a while to become familiar with overdose and to learn about how our response may or may not be working for us. The other thing I should say is that we had really highly experienced staff, and we still do. We have harm reduction workers who really know the clients, and our clients show up every day. So we really get to know not only them, but the medical response that they have to opioids, to using opioids or any other drugs. We also have a staff of nurses, the majority of whom have a lot of hospital experience. So 20 years of emerge would not be uncommon, or labor and delivery or experience in a PACU or something like that. So people who are really comfortable with having an algorithm that might need to change or that required clinical judgment. So one thing first that we observed is that no one, and this will not surprise anyone, but no one wants to go to the hospital ever. People who use drugs are treated horribly at hospitals. They do not want to go. So in our response, if we got to 5 minutes after the overdose, and so 5 minutes after administration of naloxone, and that person wasn't fully alert, we would call paramedics. And invariably, that person would be awake and refusing the paramedics before before they came there. We'd have to either cancel them, or they'd just say they were fine when the paramedics, they wouldn't even come in the room. And that happened 9 times out of 10. We also knew that there was a strong client preference for intramuscular naloxone over nasal naloxone. So it's much easier in an emergency to just kind of squeeze the nasal naloxone, but clients hated it. They hated it. And although the manufacturer says that the doses are equivalent, just the different routes, in that the intranasal is just a higher dose, just given the route. In real life, like, we just found that people were experiencing really a lot of uncomfortable withdrawal from intranasal naloxone. So for the most part, we would stop using it unless there was some kind of emergency where we couldn't drop naloxone in time. Another thing that happened is that we did notice a lot of people who maybe used too much for them, fentanyl, and seemed really uncomfortable, and talked to us about how other sites in the city, one other site in particular, would just give them a little bit of naloxone just to back off from the fentanyl that they were using, but not take everything away. So it wouldn't cause a full withdrawal, but would just back it off a little bit. So people who just found that they were a little over sedated, or they were doing that kind of fentanyl dance and they're really uncomfortable, that we would give that to them. So that was on client request. This was not for people who were, who had full overdose, but this is people who said to us, when I get like this and feel uncomfortable, I like to have a little bit of naloxone just to kind of back off. So it was usually like a 0.1 or 0.2 milligrams of intramuscular naloxone at that time. And we found that really worked well for people. And that made them more comfortable without pushing them full on to withdrawal. The other thing that happened is our site became more popular, as there's a long wait to enter the site. And we really had to look at how we could monitor clients in the site, but also think about the safety of people who were waiting, who might be using outside and maybe putting themselves in danger. And that's and I'm sure every supervised consumption site that is open today has to weigh those two things, of the people who are waiting outside versus the people who are inside. And of course, the huge thing, the big thing that changed our opioid overdose response was the introduction of benzos into the drug supply. So, and that is in Ottawa. I know there's different drugs everywhere, but here in Ottawa, I actually remember the first weird overdose that I had, and we had become, by the middle of 2019, pretty comfortable responding to overdoses. I can almost count exactly, like 3 minutes from one dose of IM naloxone would wake up people. They would just get the full, like kind of Lazarus effect, like open their eyes, like, just get up. They'd turn, warm color, look great. And that would happen almost all the time 3 minutes after we gave them naloxone. And then there was a weird overdose, and I can picture the client right now in my head. So we gave him naloxone. He wasn't breathing very well, I think, or wasn't breathing, and I think we were using ambibag on him. And then after 3 minutes, his skin started to pink up, and I noticed that he could breathe a little bit on his own, except he did not wake up. He absolutely did not wake up. He was not rousable at all to any kind of stimuli, except his O2 sats were fine. He was breathing at a regular respiratory rate. And this was very weird to me. And it was kind of scary because I've become really used to responding to like dozens of overdoses where the same thing happened and it almost always worked. And if it didn't work, there was a reason that I understood about maybe that client themselves were sick, or maybe they were using a couple substances at once. But this was one where we're really convinced that it looked like fentanyl that the client was using, and the response, and he just would not wake up. And we had to call paramedics because he was just on the floor because we had to bag him, not rousable at all. And that was terrifying to me because I had become so comfortable with opioid overdose and being able to keep people who I loved and people we saw every day, keeping them safe was really important. After a while, the word came out from drug checking projects around Canada that there were benzos in the fentanyl supply, and that really made sense. And then we had a reason for why people weren't rousable after we had responded to an overdose. But it really complicated our response because we had to figure out, is this an opioid overdose or a benzo overdose, or is it both combined? What is happening with this person? And they're not able to wake up and tell us. There are also a lot of space issues, as you see from a little picture of our site. Like, how do we monitor people? How do we make sure if they're not able to wake up, we think they're fine? Do we take them to the hospital when we know they don't want to go? How long do we watch them? How long do we let people essentially like sleep in our supervised consumption site, knowing there's a wait of 5 or 6 people outside? There are also safety issues where people would kind of wake up a little bit and try to leave, but then they would fall immediately asleep outside. And we know from some of the accounts of people who've experienced, benzodope is what it's called, is that they're really at high risk for assault, sexual assault, for having their things stolen. I was really worried in Ottawa in winter when it's like minus 30 outside that someone would freeze to death because they left and just fell asleep. So we had to kind of determine how you know awake is someone, like how awake do they need to be for us to feel safe for them to leave the site. Another big thing that happened is that all over town there are people, and probably all over Canada there are people who are very sedated. Someone walks by and sees them and responds as if it were an opioid overdose. And not to criticize those people at all because they're trying to keep people safe, but our clients were then really used to kind of having a benzo overdose on top of opioid withdrawal. So getting multiple doses of naloxone, and then waking up completely miserable because they were in withdrawal like a few hours later. And they became really afraid of naloxone overuse, either by paramedics or out in the street or even by their friends, because people were like just did not know if someone wasn't waking up because of opioids or because it was benzos or something else. So we actually had it after a while, like 2020, at the beginning of the pandemic, a lot of people saying, oh, I'm allergic to naloxone. I'm allergic to it. Please don't use it on me. And that's totally understandable response to people who have had way too much naloxone and their drugs taken away from them, like chemically, so many times that they would just say, please don't do anything else. Just use oxygen. Don't use naloxone on me. And that was really painful because we had really prided ourselves and in our supervised consumption site for using as little naloxone as possible, realizing that that's the client's preferred that we not use a lot, and knowing that opioid withdrawal is quite unpleasant and miserable. So the latest version that we had, and I feel like it was late, maybe early 2020. I'm not sure exactly when we revised it. Um, and overdose stayed the same. When someone was in a serious overdose, that response, same thing. We often wouldn't call paramedics until 2 doses of naloxone, but otherwise pretty much the same. But for drowsy clients, we would observe them for only 30 minutes before we would have a disposition discussion. So we could not watch everyone for an hour while they were having this benzo overdose or just a benzo-y time. We just didn't have the space for it, and it wasn't really fair for the clients who were outside. So after about 30 minutes, we would talk about what to do. Luckily, in Ottawa, we have a program run by Ottawa Inner City Health called Targeted Engagement Diversion, which is basically what people call a sobering center. So we could call paramedics. They would take them over to this program, which is just a few blocks away, and people could kind of sleep it off. And in cities where they don't have this, I really feel for them, because you're making the difficult decision of whether you're going to send someone to the hospital who just needs to sleep for a few hours, just sleeping off the benzos, or whether or not you're just going to keep them there, taking up a spot for someone who might be using drugs outside. For the nodding part of it, this is where it really got really complicated, because we really had to figure out a way to distinguish between the opioid overdose and the benzo overdose. And it usually was a combination of both. So this is the point where we really started looking at people's respiratory rate. And I know if you've ever worked as a nurse in the hospital, we're not really great at charting respiratory rates, and everyone breathes at 16, and we don't even really think about it so much as an indicator of clinical health. But really, in a supervised consumption site, you have very limited tools to determine what's happening with people. So we started looking at their respiratory rate, because opioids are really great at depressing respiratory rate, and we generally don't see that respiratory depression in a benzo overdose. So if someone is not rousable but breathing well, not working breathing, nice good breaths 12 or 13 times a minute, I'm thinking that is probably a benzo overdose. I am not going to give that person naloxone. There were then a lot of people who were breathing at a really kind of a borderline rate. And this is a really classic, like, combination opioid benzo overdose, where they were breathing maybe 8 or 9 times a minute. And maybe sometimes their O2 sat was okay, or it was a little bit low. At that point, we started to give smaller doses of naloxone, so 0.1 or 0.2 milligrams, just to back off on the opioid portion, to see if we could get someone rousable enough so that they could, like, continue on their day and be safe, but not enough to pull them into full withdrawal, knowing that they could have benzos on board and might get in and be fairly miserable when they woke up. And this is probably the most common way that we administer naloxone at our supervised consumption site in Sandy Hill right now, is giving people these small doses, just to kind of back off the opioids a little bit, but not push them into full withdrawal. We don't see as many of these full classic, turning blue, not breathing overdoses. We see a lot of this, like, really prolonged sedation that sometimes has a low respiratory rate, or sometimes does not, and sometimes needs oxygen supplementation, but sometimes it's not. Sometimes we could just stimulate breathing by asking people to breathe. My staff hated when I would go in and do that, because they couldn't do that all the time. It's really quite staffing intensive to have someone remind someone to breathe every few seconds, but you could do that as well. So this is really how our overdose response really changed with the introduction of benzos into the supply. So what lessons did we learn from at least the past 4 years of opioid overdose response at our site? It was that respiratory rate is important. It is an important number, and it tells you a lot. And it's actually the standard of care for post-anesthetic care, or for anyone who's on opioids for sedation, is that you're monitoring their ventilation. So not just their SpO2, but also monitoring whether or not they're breathing okay, so that they have to not only be taking in oxygen, but clearing off the carbon dioxide. Because and I don't want to go too technical about the respiratory physiology about this, but if you are not clearing off that carbon dioxide, that can make you sleepy as well. That's not going to help in one of these overdoses where you're not really waking up. It's not really a good thing for you to be even sleepier. SpO2, so your O2 sat, your pulse oximeter, is just telling you a number. And what I would teach people is that number can mean a lot of different things. It sometimes is helpful, and sometimes it is not. So one, we know that in the context, if you're giving people supplemental oxygen, but they aren't breathing enough, like, you may not be noticing that they're not ventilating. So they could have a normal O2 sat, but not clearing off the carbon dioxide. So still retaining that carbon dioxide, it could affect their mental status and ability to wake up and go about their day. We also know that people have COPD, which is many of our clients, whether it's diagnosed or not, don't walk around with normal oxygen stats and should not probably be at 100% oxygen. So that's something where we had clients where we knew after the course of time that, hey, they never get above 88. And because we also operated a primary care clinic, we sometimes knew people's medical background and knew. So though we can't just go by the drowsy nodding overdose algorithm and just follow it strictly with someone who has COPD, which is quite a few people who use supervised consumption sites. Another thing, and there's been a lot of recent studies about that, is that about pulse oximeters is they're not really the best at measuring the amount of oxygen in the blood of people who may have darker skin just because of the way they work. So it might underestimate hypoxemia or low O2 sats in that population. So that's important to teach people who are responding to overdoses as well. That number, if it's 85 or 90, it could actually be much lower than that in someone with darker skin, just because those devices weren't really tested very well on racialized people. And oxygen saturation in general is a late information. So it doesn't really show you their respiratory status right now. It shows you later. In a very busy supervised consumption site where you're checking people's oxygen intermittently, we don't have continuous pulse oximetry. You could miss something by seeing someone far away, checking someone's O2, not paying attention to them, not really looking at how they're breathing or their clinical state or what color they are, and just going by the number, and you could miss them for a few minutes. And that overdose could progress to something that you don't want it to get to. And I put this picture on the right. It's actually from a paper on a device that was tested at Insight to measure opioid overdose. And instead of using pulse oximetry, it just uses respiratory rate. So it's a phone, so you don't have to have extra equipment. I don't think it's for sale yet, but it's been tested. And just keeping it on someone's body, able to measure their respiratory rate, and does a fairly good job of predicting whether someone is having an opioid overdose. Some other lesson learned, and this is a really important one that I'd love to get across, is that when you're assessing someone's level of consciousness, we use what we call medically painful stimulus, but that doesn't mean that we're causing pain so that people would wake up. Because if they're not going to wake up, especially in a benzo overdose where nothing is going to wake them up, you're just causing them pain and possible tissue damage. You're supposed to cause a little bit of basically discomfort. If they don't wake up, then that tells you that person's not responsive. We saw so many times people, especially in the community after the drug supply changed, people who had like horrible wounds on their sternum from very hard sternum rubs that desperate people, well-meaning people would try to give to wake people up who are not going to wake up with anything like that. So we actually don't use sternal rubs in our supervised consumption site. It was something that I was taught not to do in nursing school. And just because of the ability to cause injury, as well as the fact that you're really in people's personal space, we really avoid them. And we teach people to use a trapezius squeeze or a glabellar tap instead, or even just like a slight pinching of the fingers, but nothing that would cause tissue damage, especially because of the drug supply and how people are just not waking up. Another thing that we learned is that after having used an ambu bag many times on people, it is the most technical skill. So injecting someone with naloxone is easy and you can teach anyone to do it. Breathing for people is a little bit more difficult. The great thing is they usually don't have an obstruction. So it's important to tell people who work in supervised consumption sites that this is technical and you can do it wrong, but it doesn't need to be perfect. You don't need to be afraid of doing it. And I found that people are really afraid of bag valve, of using the ambu bag, but you're almost reminding people that they need to breathe. It doesn't have to be perfect for it to actually ventilate people. It's just a little pressure, and they'll often take a breath on their own. We also talk to people about the staff about differential diagnoses and about the fact that someone, just because you find someone down, it doesn't mean necessarily there's an opioid overdose, or if they're not responding to naloxone, it could be something else. And low blood sugars are a really common cause, especially for a population that, we have quite a few clients who have diabetes will get insulin at the pharmacy, but won't be able to make the shelter meal because they have to get their methadone or won't have enough money to buy food. But their insulin has been adjusted for food that they haven't been able to eat. And so we really had to let people know that you have to, if naloxone isn't working, to examine other responses because it usually worked. I can count on maybe two hands the number of times we had to give 3 doses of naloxone to someone to wake them up. Almost always it was 1 or 2, or usually the smaller doses of naloxone. So when we would hear in the community that people need 10 or 20 doses and they woke up, to me, I wasn't thinking, well, there's some crazy drugs out there. I was thinking these are kind of people are not waiting, or there's something else going on with that person, because really that's a lot of naloxone and something else is happening. And the final thing is that staffing levels will affect your response. So as I mentioned, when I used to go into the injection room and remind people to breathe, you can only do that if you have so many people. So if you don't have enough people, your response might have to be a little bit more conservative, and you might have to use more naloxone. Luckily, we have usually had enough staff in a small room that we could really respond to minute changes in client presentation. So why is all this important? I think one thing I tell people kind of counteracts half of what I just said is that the most important thing in opioid overdose response is time, and almost anything you do will help someone. And we know this because we tell people and we say often that no one's ever died in a supervised consumption site. I hate that saying because it holds us to an impossible standard that you would never hold to another medical setting ever. You'd never try to say that it was 100% perfect. But people do say that about supervised consumption sites. And I think we are held to that standard, unfortunately, that people don't necessarily trust our response. So in order to counteract that, I try to make sure that our overdose response was really evidence-based. There's clinical expertise behind it. They're really paying attention to what was happening with our clients, that we weren't just going rogue and doing whatever, but people were following established protocols and had reasons for going around them. And that's really important because our services are always under attack, unfortunately. And we need to kind of be able to show people that we are providing really good quality clinical care. No matter what, it doesn't matter whether you have medical people in a site or not, the care has to be really good because we're held to that standard. The other thing, and you'll see throughout all the different iterations of the protocol, is that we really tried to respond to client preference. So the thing about supervised consumption sites I mentioned before is that people don't have to go to them. It's their choice. And so it's a service for them. And that's really very different from a lot of other medical settings. This is a service you can avail yourself of. And so we have to respond to people's needs. So if people do not want to wake up in misery withdrawal, or they want to be able to trust the response that we're going to give, that's really important, that we listen to our clients and their experiences, are outside. And if they're really tired of getting 10 doses of naloxone outside, I think it's really important in a supervised consumption site that we hear that message and we try to be creative about our response in order to make them feel comfortable where they are. So I think that overdose protocols should be, I'm never going to recommend it should be one thing, that all protocols have to be the same, because all clients are not the same, all drugs are not the same, all studies are not the same, but they should be evidence-based. What are other sites doing? And they should be trauma-informed. Being a part of an overdose, responding to it, experiencing it, witnessing it is traumatizing. Even many years into this crisis, it's still really hard for people to see this happen to their loved one. It's hard to wake up. People get very embarrassed about having an overdose, and they feel like it reflects poorly on them. So how do we make that experience how do we minimize the trauma that we're causing people who have already been traumatized by the drug war and by healthcare in general? And they should be living documents. It should not be, in hospitals, they'll set up a protocol and they'll use it for 10 years. That's not going to work given the drug supply and the different clientele. It's just not going to work. It should be a document that you can revise based on input from staff and clients. Should also be influenced by the drug supply. I can imagine that, what we're responding to here in Ottawa is a lot of benzos. I know there is xylazine in the States that we're responding to. At the same time, I know also in Quebec, people use a lot more stimulants than they use opioids. It's just a different place. And so they might have a lot more nuance in their stimulants overdose response than we would have in our site where people mostly use opioids. So it really should be tailored to that drug supply, and also to the built environment of like, how big is the site? How many people do you have? How long is EMS response? If I operated a site in a rural area, I might give a lot more naloxone, just knowing that I don't have as much of a leeway in terms of having people respond. And so I think it's really important to take those into consideration if you're designing or changing your response. And obviously they should be created and modified with the input of people who use supervised consumption sites. And this is a quote that a client said about all the supervised consumption sites in Ottawa, that they're all a little bit different and they have a little different flair. And I thought that was a really nice way to describe it. It's like kind of going to a different restaurant. It's not like, maybe it's like going to a different hospital, but I like to think of it as like, it's just, you know, hey, if you're feeling this way, you go to this site. If you kind of like those people, you go to that site. So the sites can't be one size fits all in any way, and they shouldn't be. The main takeaway is that supervised consumption sites are a unique part of the healthcare system. Whether or not medical people work there, we are a part of that continuum of care for people who use drugs, and we're also a source of knowledge and expertise. So it's not, we know what is happening with the drugs from our clients. Our clients tell us, and we see what is happening, and we can provide that information to, you know, the rest of the continuum of care. It's not just a top-down system where people tell us what to do. I think more and more people are acknowledging the expertise of people who work in supervised consumption, and people who use drugs who work in supervised consumption, for sure, to know that they really know what's happening on the ground, because we see it like in real time and are able to speak to people who use the services in real time. And those are my references, and that's it for my presentation.
Tali, you were fantastic. Thank you so much. So much for sharing. I know I was speaking to you before and just saying your personal experiences and being able to share those with us so honestly was all I wanted, and you did that and then some with the information that you provided. So huge thank you for doing the presentation in the first place.
Thanks.
As always, there's the comment box if you do have questions or comments that you want to raise. You're just getting so amazing, and thank you, of course, in the comments. Otherwise, we'll keep you for a bit, and I have tons of questions. I always do, and I don't mean to take away from, because some of my questions might sound more practical, because I am not used to supervised consumption sites, so I want to benefit from your knowledge, but that's not to take away from all the experience and the emotion that you put into the presentation and everything else that's there with it. So if you're hearing something that I'm asking for a question and that flags you for a question, just put that in the chat box and we'll address that as well. So you kind of addressed this one, I think, but just to be super clear, what can be used? What substances can be used in a consumption site? Are there limits?
Wow, I didn't. Yeah, no, there's no limit. So you can, at least in Canada, there's, I mean, I can't imagine. So really, the substances aren't limited. The modes of use, the routes of administration are somewhat limited. So you have to apply for an exemption. So we start out with an injection exemption, and we had to apply for an exemption for snorting, for example, which seems wild because snorting is somewhat less, could be less harmful, could be thought to be less harmful than injection, but we had to apply for those specifics. It's really the routes of administration. And for example, like inhalation, so smoking is only allowed in a couple sites in Canada, just because you need to have this whole infrastructure to do it. So the drugs, you can use any drugs you want. And I didn't put up stats with drugs that we saw, but over the course of time, I think most recently, the last time that I did the stats, it's like 60% opioids and maybe 15% stimulants, and then like other things, a lot of prescription stimulants, and the opioids. You know, we our site is near a safer supply site, so there's a good amount of Dilaudid that's being used that I imagine is, you know, prescribed or gotten from people who've been prescribed Dilaudid. At the same time, a lot of people who are on safer supply also, they use their safer supply at home because it's more predictable, and they use fentanyl in the site, which makes sense.
Yeah, perfect. Thank you. That I kind of thought that when you were speaking about stimulant use, but I just wanted to clarify that it could be anything. So kind of to tie into that one, but also a question on its own. Can you tell us more about how the process actually works specifically, I guess my question is about intake, because you'd mentioned at some point that clients might say something about, oh, I have an allergy to naloxone, and you have so many repeat clients that you just happen to know some of them, so you get to
Right.
know their health history.
Mhm.
But the client that comes in that's a new client, is there any mandatory information? Wanting to keep it as open as possible, obviously, coming from the medical lens,
Yeah.
allergy, COPD, like you said, and having a different requirement for their SpO2.
There's, you know what? There's information that we collect. It is not in our site, in sites in Ontario. There's no need to verify that information. So we usually get a name or a handle, maybe someone's real name. I don't know. We usually get an age. But none of this is verified against anything.
Yeah.
So that's part of it. So we will do ask ethnicity. There are some questions that we've asked for research purposes about whether people overdosed in the past 30 days, whether or not, what drugs you usually use, but those are kind of statistical and you do not have to answer them. But usually we get at least an age, but again, that doesn't have to be verified. And so that's on registration. And we don't really keep a lot of medical information about people. We used to have just papers. Now there's a little bit more of kind of electronic charting syndrome system, with mostly just that we know the clients, and we do get a lot of repeat people every day. Like we don't often have new clients. That's kind of happens maybe 4 or 5 times a month. It's often the same people, and we get to know them really well. And because we also have a primary care clinic and an addiction medicine clinic on site, then we happen to know, like, so we don't share charts at all, but you just know in your head, like whether someone tells me they have COPD, and like it's probably true.
Yeah, absolutely. Would you see the need to collect more health information or more of any type of information as a barrier to
Oh, I
access?
see it as a barrier. It's been, so that research has been done. It's absolutely a barrier. And not only because people don't want to give that information, but also for time. Like people are like, they're usually in withdrawal. They want to get in. They don't want to give a lot of information. They don't trust it's going to stay safe. So I feel like we really need to be careful about the information that we collect and like what we're using it for, because if we're not using it to help people, then it's just information collected for no purpose. So really the drugs like the most important thing is, what drug do you think you're using? We have asked people, so on the visit, there's questions about what drug you're using, whether you've had a recent overdose, um, or sometimes they'll ask people, like, or people will volunteer whether they've just left jail or left the hospital, which is a really high risk of overdose because their tolerance is down. We've also asked people whether they're on methadone or Suboxone. And I think that was also done. I'm not sure exactly why that was done, but I actually have a whole other Medify presentation about that and the correlation between OAT and overdose. But we've asked a few little questions, but again, not verifiable, and people don't have to answer any of them. And even what drugs, if people don't know, they don't know. And oftentimes they don't know what drugs they're using. We don't know what's in the drugs. So yeah.
Yeah, but that's actually really good to know that that question kind of comes up, because like you said, in terms of interpreting response, if you don't have any idea to begin with, although I'm sure you get very familiar with what things look like, it's nice to have that additional piece of info, I'm sure, when you're going to respond of, well, they said they were using this, so
Yeah.
let's see what goes.
Yeah. So we'll even like if someone says they're using fentanyl, like that's actually like a note that they're like, because almost all of our opioid overdoses are fentanyl involved. Like we don't generally see overdoses on prescribed opioids at all, just for many reasons. But so that we'll kind of flag fentanyl use, or flag like that thing about hospital or prison or something like
Right.
that, where we feel like, oh, this person is really high risk.
Which is such a good point. You have a couple questions popping up in the chat. So
So
one of them, oh, sorry, did you want to go through them
no,
yourself?
no, no. You can ask them. I don't.
I saw the first one, which is, what, if anything, is done to encourage a link to treatment or addiction medicine?
So there's a lot of things. So we are really lucky in our site that we have an addiction medicine clinic on site. So about half of our clients actually are already on opioid agonist therapy. Um, at any given time, but they can get addiction treatment, like in the form of medication, on site immediately. And our nurses also work kind of doing addiction medicine, so they're cross trained. So people are really familiar with how those treatments work. And we also advocate for people, like if they're like, well, I haven't got my dose of methadone yet, like we really highly encourage them if they want to go to detox. And we were talking about this before before the presentation, but we will call people to get them into detox if that's what they want. So we're really there for what the clients want and need, but we're really lucky in that those services are literally like 5 steps away from the injection room.
Nice. Which really segues into this next question about, you mentioned that this clinic is near some shelters. Do you have a working relationship with these shelters? For example, do you get preferential intakes into some of these shelters or withdrawal or anything like that?
But there's no preferential intakes. We do have a working, so there's an injection site that's in one of the shelters in Ottawa. And they will refer people to us if they happen to be closed or if people just want a different experience. It's a resource that is really commonly advertised to all people who are in shelters. And the shelters in Ottawa are all within, well, most of the shelters in Ottawa are within a 5-minute walk of us. So and a lot of our staff actually work, especially our non-clinical staff, work at shelters as well as working at the site. So they really know all the programs and we know all the people. So it's a kind of a small community. Yeah.
Yeah. The next question is, does your site employ peer workers or individuals with lived experience? And I'll just tag on to that question because I had a question. You mentioned earlier that I think you said that the staffing isn't regulated by Health Canada. So I was wondering what you would see as like the perfect example of a staffing for.
Oh, that's hard. So first, the one thing that actually is regulated is that you do have to have people with lived experience as part of a supervised consumption site in Canada. So that is regulated. So we do have peer workers because our site is really small. So it's a really small room. And originally we just had one nurse in the room for like a year. And that did not work so well because you need more than one person to respond. And also from the fact that it can just be kind of like, it's hard for one person. It's like you're a lifeguard a little bit looking at 5 different people. You get kind of, tired and you're not really seeing everything. So we put 2 people in the room. Currently we don't, the people, so they're called community workers at our site. They work, it's unfortunate during COVID it hasn't been open, but we have our post injection space is also a drop-in space that people can use whether or not they've been using our injection room. So it's a place where people can get coffee. They have like a TV. Sometimes there's music played. And so our community workers oversee that site, that part of it, and the programming and whatever happens in that site. So that's really their space because our room is actually kind of really small. It's just basically for just the injection part. Because of COVID, we couldn't have food inside. And so that's, unfortunately, then became more of well, not unfortunately, but they became more of the intake at the door, staffing our needle exchange, and kind of doing the initial, like, hey, you want to come and use the site? Like there's a 5-minute wait, that kind of part of it. Other sites have larger spaces and have their peer workers or community workers in the injection room responding to overdoses. And it's just our room was really small, and some of the people who were involved in the design of our site at the beginning, some of the peer workers didn't necessarily want to, they thought it would be triggering to be part of the actual response. And so preferred to kind of work in our drop-in space instead. So that's kind of continued like that. But other sites have really different models. In terms of the perfect staffing, that's a kind of a controversial issue. And I think it just has to be enough people. And I don't actually think that you really need medical people to be, and I think that requiring too many regulated health professionals is really a barrier because we're quite expensive. And obviously it's very hard to find nurses. And part of the reason why I'm not managing the site anymore is I needed a break from trying to staff it because it was really exhausting during COVID and a nursing crisis to try to do this. So I think the perfect staffing complement, I'm not even sure if I could come up with one, but it should be, for a real true response where someone is like blue on the floor and you need to breathe for them, like ideally you have 3 people at a minimum. So whatever staff you have around, like if you could have 3 people respond to one of those serious overdoses, that would be ideal. Fewer than that and it just becomes really difficult.
Yeah. And I'm sure that would vary, like you said, based off the super tiny spaces versus a room where you have more space to move around. 3 people can walk over each other pretty quickly when there's not much space to move.
Yes, it is quite cramped, but we see everything. And the benefit is that in a small space, it's like a chat, like we're constantly chatting.
Yep.
I've been in other sites where the clients are a little bit farther removed and you aren't really part of it. And I can see a benefit to that too, because you're not medicalizing, like when people are trying to get high and like, why is a nurse there? And that's weird. At the same time, I've learned so much and had great conversations with people because we're just kind of chatting like a small bar or something like that is how I look at it. So I can see benefits to both those kind of built environments.
Yeah. So to continue with the medicalized versus keeping it more
Hmm.
comfortable, I guess. You've mentioned a couple times, so this is my naivety speaking again, but you've mentioned a couple times response on the floor, and your picture as well showed chairs, and then I was like, where do you respond? On the floor. So coming, from your expertise, is responding on the floor the best way to go, the only way to go? Could there
So
be something
yeah,
else?
that's a really good question because it's funny when the site was designed. I will say, I hope there's no one that I'm working with. Let's call it. It was designed by very medical people or people who had been involved in acute medical response, right? So and I wasn't there for the physical design of the space, and so then when I kind of came along and looked at it, I was like, well, how are we going to respond to an actual overdose where we need to breathe for people? And there really is no other place but the floor at that point when you're breathing, just because like in order to get, it's like the flattest plate in case you need to do CPR. If you're sitting in one of these basically office chairs, it's really hard, like you're going to obstruct if you're going to try to like bag someone. It's not going to be really possible. So I've seen people try to do it in a chair and it hasn't gone well. And if we put everyone in hospital beds, I think everyone would fall asleep and leave and stay there forever. And that wouldn't be good. So the floor is really, that's how I've seen it been done. And it's the only real option if you want a flat space. So we do bring people down from the chair onto the floor if they're having an overdose. And I can't think of another, and maybe someone else has another idea of what we could do, but it's much easier to bag people and respond in that kind of when you have enough room.
And other clients during this response, what happens to them? Are they asked to stay where they are, to leave the facility? How does that work out?
That's a good question. So they stay where they are. People are unfortunately really quite used to it at this point. And sometimes people will give us advice. Sometimes they'll help clear the room. There are some people who find it very triggering and will leave and will let people leave. It's a very small room. And so sometimes people are stuck where they are, and that's really unfortunate, but that's kind of the design of the space. One of the issues that we had, it was during COVID, and part of my like stress at the beginning of COVID was that with these aerosol generating medical procedures and like, are we spreading COVID everywhere? You've got a room where people want to be observed for their safety. At the same time, like, are they exposing themselves to COVID? So we really had to think about ethically, like we had to actually reduce the number of booths that we had so we could give people some space in case we had to do a procedure that would spread COVID. And we also kind of had to let people know, like, you might be at more risk for COVID being in this space. There are other sites that just went down to one person because that was the way that they managed it. And we felt like that was really their risk of death from overdose was higher at that point than the risk from COVID. And thankfully, there's a lot of effort to get people vaccinated and people who use our sites. And we did vaccinate people on the site. So then it made us feel a little bit safer about that response.
Yeah, that's great. This is one of the questions in the chat. You'd mentioned the extreme pressure of your previous position, especially in the last few years. What is the level of care or service you have in place for the staff, especially for, as you mentioned, triggering events for people with lived experience?
That's a really good question. And I don't have a wonderful answer to that because I think that's a question throughout healthcare. And I think it's something that's very much on the mind of people who operate supervised consumption sites. And I think for me, the pressure, it's not so much watching the overdose. And of course, it's why we gave the option for people with lived experience to work in a separate space from where they had to watch overdoses all the time. It wasn't so much that as it was just like people dying. It's like getting to know people and having people die. So in November, I think 5 people I knew died. I've had coworkers who have died, and it was that. And I don't have a great response for that. So we did start doing some group sessions with people who are working that day once a week so they can get and talk about their specific issues and moral distress they might feel about different situations that happened in the site. I think that worked for some people. It didn't work for others. For the nursing staff, especially, like nurses are really not taught to talk about painful things at work. We're like, avoid it, go home and drink a bottle of wine. Like, no, we don't have great coping mechanisms. And so that was where we found the social workers really loved that. The nurses didn't really, like some of them didn't feel that it was super valuable, but at the same time we recognized that everyone was getting burnt out. And I don't have a great answer to that. And there's been literature written about it, but it's hard given that we don't have a lot of resources and a lot of money and a lot of space, and the staffing in all of healthcare has been so poor that it's hard to say, hey, we're going to close early and take an hour and chat about things. But then we also have people who need our services, and then balancing that was really difficult.
Yeah, absolutely. And I love that you point out that different professions might, just like different people, but different professions might respond in different ways to different options. And I've seen that myself where the nursing staff in my profession or at my location respond completely differently in terms of their wants and needs versus maybe the counselors that are on site and what they enjoy for debriefing and feedback. So I think that's very true for many places.
Built into social work, this idea of clinical supervision is like mandatory for people who are social workers and doing some, and it's not for nursing. And that was actually a really another interesting thing about it, because I think it was hard for me to even recognize that need amongst the staff, because I was so used to a system where I would see something horrible and then have to do something very normal 5 minutes later. And so that had really become normalized for me from acute care settings. And so going into like a setting where people were maybe used to a little bit more care about their mental state, it was just kind of like a disconnect for me.
Yeah, absolutely. So this is just a question that you don't have to have an answer for or know an answer for, but I'm just curious what your opinion is with decriminalization kind of creeping up and becoming more present in BC. How do you think that will affect the consumption sites? Because many times in the presentation you said, these are decriminalized rooms, which makes them really nice for people to be able to go and feel safe in that room to use. So if that's no longer a street concern, how do you think that affects the site, or doesn't affect the site?
I think we'll still need supervised consumption sites. I mean, I think that, a whole lot of people use drugs in their home. So a lot of our clients who are using the site are homeless, or I mean, also people who are, it's their lunch break at work. But usually there aren't people who are working every day, and they're usually experiencing homelessness or sleeping rough or couch surfing, something like that. So people need a place that is clean to use drugs, where they can take their time, no matter whether or not those drugs are regulated or not regulated, even for like infection prevention. And I think that's an important thing. Like there are a lot, people who at the beginning we had more stimulant users using our site, and they wanted a place to really be able to wash their hands and prep their drugs correctly and all of that stuff, and make sure they weren't losing everything. And it had nothing to do with overdose. And so that's why I still think that there will be supervised injection sites after. They still have a need for a place for people to prepare their drugs in the way they want to, and it's in a safe space where people are watching over them beyond overdose.
And I'm glad you brought up stimulant use having specific needs, I guess, or wants in terms of their site. So for that, at least my brain, medicalized again, always goes to psychosis. And sometimes presentations are difficult or challenging. So do you see this? I'm assuming you do. How often do you see this, and how is it managed?
Really rarely, actually. So stimulant overdose, we didn't even have a protocol up until like 2 years ago for stimulant overdose. And so we talk about chest pain or seizure. I have rarely seen that. I've seen some overamping where people were obviously uncomfortable, and what we do is just supportive measure. We literally have a room. It's a nice small room. It can be dark, but we still have a window in it. We might get a fan, some water, cool cloth, let someone just calm down. In terms of psychosis, we don't see that a ton, and I'm not sure the reasons for that. I think sometimes when we think of meth related psychosis, in an emergency room setting, I think sometimes it's confused with a mental health crisis that may or may not be exacerbated by methamphetamine use. I do think that people in our site felt more comfortable, and we also like have had a psychiatrist on site once a week, so we might have an overrepresentation of people who are actually getting adequate mental health treatment. The other thing I would say is what I think sometimes we think of as meth psychosis is also a real lack of sleep, which also could be attributed to meth. But that's where we know people would just have said, I haven't slept in a week and I haven't been able to sleep in a week. And that's often where people's mental state was not really good. But it's actually quite a rare event compared to when people talk about it happening in an emergency room setting or people getting violent, because that's not really something that we saw, which makes me think that it's not just about substance use. Like I didn't really see that many people who were fine beforehand, injected a stimulant, and then were psychotic afterwards. Like that was not a very common occurrence. And so I think there's something else going on, or there's something about the environment or our clientele that is a mitigating factor.
I think all of those are potentially combined to be real reasons why that would be the case for your site and probably other sites as well. We're closing down on our time, so if you have any last minute questions or comments, throw them in. But I'm going to ask another question, hopefully for everyone that doesn't want to ask this question, but you spoke many times about respiratory rate, and you even called out nurses, which I love, for not doing proper respiratory rate. I worked in Emerge. I definitely charted whatever number when patients were totally fine, because they were totally fine. So I'm not going to sit there and count the respiratory rate.
Exactly. Yeah.
And I know this happens all over the place, not just with nurses. So I would love to hear your responses. One of your key points was time. So your responses are very timely and you need to be on that person really quickly. But you're also really taking into account this assessment. Give us the whole rundown of how do you do a proper respiratory rate assessment?
That's always what you're watching. So if you're thinking about it and you have a room where you're watching 5 people, first of all, I'm counting everyone's breath all the time. Like I count my cat's breath. Like I'm wondering, like, are you breathing? Like, and this is probably a little bit of a trauma response. It's not great, but I'm always wondering whether people are breathing. So you've got 5 people in a room and you're wondering, okay, can I see their face or are they talking? Like, can I see them? And so then if those people, we don't need to worry about those people, because if they're talking, chatting, whatever, don't need to worry about them. Generally speaking, people who I know never overdose because they only or ever inject prescribed Ritalin, and it's very clear what it is. Not necessarily worrying about those people, but other people who are, especially people using fentanyl, I'm looking and watching them from behind. So there's mirrors in front of me, and in most supervised injection sites, they have mirrors in front of the clients to help them for their injection, but also see them. So you're
really
watching
cool. I was wondering what those were in the picture. So I'm really glad that you said that.
So there's mirrors also for injecting in your jugular, but the mirrors in front of the clients is mostly so you can see their face, not in a non-obtrusive way where you're not like getting all up in their business. So you get really good at kind of like seeing, people's like, just their body kind of like heaving or not. And so from behind, I'm seeing where people are breathing. If they're not breathing, or if I can't see it, and winter is always a difficult time because people in Canada, they're wearing big coats and you can't see what's happening. I would just kind of slowly walk around, like realizing that that person might be just like very concentrating on their injection. I kind of slowly walk around, see if I could get a picture of them in the mirror to see what their color looks like. The mask wearing during COVID made that a little bit more challenging, but it wasn't impossible. Oftentimes you'd see people like, at that point, you're just like, is there regular breathing happening? And is it, you don't necessarily have to count for the full minute to realize, like, are people breathing roughly every 5 or 6 seconds, or are they absolutely not breathing? And you can kind of tell from the angle. If people really had their head on the ground like this, I would kind of bother them every minute. Or I'd say, hey, can you wear, if they're not on oxygen, I wouldn't worry about it being confounded, but can you wear a pulse ox for me? Like if you want to have your head down, can you just wear that so I can just take a peek at it every little bit? Because I knew that eventually if they stop breathing, that number usually goes down. But the response is interesting because it's not, you don't want to make people feel uncomfortable. You don't want to be in their space. You don't want to spook them if they're trying to get a vein and it's impossible. So you have to kind of be like sneaky about watching people, but not being weird about it. Or you just engage people in conversation. Or sometimes I'd be like, Bob, you okay?
Yeah,
And
absolutely.
I'm fine, like stop bothering me. Yeah.
Uh, Tali, thank you. I thought that was fantastic. I honestly learned so much, and I'm so grateful for the way that you present, and it's so open and really made me comfortable. Hopefully, it made everybody else comfortable as well. So, huge thank you. I'll just
Thanks.
do a quick reminder for people that are here that the evaluation should be present on your screen. So, if you can fill that out, that really helps us with future presentations and how we can tailor them to suit you better. So you're getting lots of thanks, which is no surprise. But otherwise, I'll say thank you guys so much for joining us tonight and have a good evening.
Thanks.